today by my co-chair, Dr. Lois Swisher, as well as our interviewee today, Dr. Sally Spencer Thomas. She's president of the United Suicide International and contributor to workplace suicide guidelines, and has been making huge efforts in this place of workplace suicide. And you may also recognize her from a TED Talk that's online and gaining some momentum about the suicide of her brother. Thank you so much for joining us today.
I'm so honored to be asked to contribute on this really important day, Perry and Lois. Thank you for inviting me.
We always start in the same place in these interviews, and that is for you to share your story, a little bit about yourself and what drove you to the work that you do today.
Yeah, thank you. So I'm a psychologist by training, and was in the field of mental health for about 16 years when my younger brother died by suicide in 2004. And as for many of us who've lost loved ones or colleagues or friends to suicide, it's like one of those before and after moments in our lives. And so I decided, like, wait a minute, I was supposed to be an expert in this. I was supposed to have all this knowledge and skills and so forth. But when I started to dig into the research at that time, I realized there were so many things that I didn't know. And one of the things I didn't know was the fact that the majority of people who die by suicide are working aged people. The majority of them had not stepped foot, at least that was the data in 2005, had never stepped foot in any kind of mental health resource. They had one attempt and it was fatal. And so for me, that was the most important gap to fill. How do we reach these people? And if they're not going to show up in other types of systems like education systems or in other like faith community systems, where are we going to find them? We're going to find them at work. Work seemed to be the most cross-cutting system out there that was not currently addressing suicide prevention in any way. In fact, they were recoiling against it, like, no, that's a medical issue. And I said, but they're not reaching out to mental health providers, but they're showing up at work. Maybe you could help. And so really that was the beginning of this now almost 2-decade long journey of trying to figure out how to engage workplaces to become more proactive and strategic in suicide prevention.
When I work with physicians, a common question usually comes up, and there are a lot of regulations in place in our industry, among how our hospitals are regulated, as well as even how our residency training program or medical schools are. And the answer I always get is, well, we have access to mental health services. There's a phone number that we can call, and there's a disconnect between a resource being available and an active workplace suicide intervention program. Can you speak a little bit about that and what really a good intervention program would look like in general?
Yeah, and I will go even more broadly to say it's even more than a good intervention program, it needs to be a culture shift because we could build the most incredible intervention program. But if the word on the street is physicians take care of their own problems, physicians are strong, we are the helpers, we are the experts, we don't need this, which is pretty much the word on the street, then nobody's reaching out, even to the most beautiful intervention program. So yes, we need to make seeking help easy. We need to make it culturally relevant to physicians and healthcare professionals across the board. But the step prior to that is we need to make it a matter of fact, this is what we do around here kind of culture. We take care of our emotional health. We look out for one another, and all boats rise when we do that. So that's really where, the national guidelines for workplace suicide prevention is really trying to get workplaces to think of is far more proactive in, the upstream, midstream, and downstream approach to suicide prevention.
One of the things I really love that your organization does is you frame it in almost a business sense. You're making a business argument for the importance of this. And it's very true in the healthcare industry. To get change to culture, to get leadership to buy in, they need to understand the true cost of suicide, the true cost of people who are suffering in extreme distress. Can you talk a little bit about what you found in terms of a cost to a workplace when we have individuals that are in distress or that die from suicide?
Yeah, there's a lot of layers to that question. So, one is, we've had health economists literally do return on investment studies on what a proactive suicide prevention in the workplace does to return that impact to the organization and the larger community. And so people recoil from that data because it's very, how much is a life worth question. But when they look at just the specific metric of how many years of life was lost and what were those years of life worth in terms of their business productivity, then it's just a clear-cut formula. There is no number we can put on the value of a human being's life, but we can estimate what they would have brought into an organization or to their community or to their family and so forth. And then when we look at the cost of doing a suicide prevention program and the return on investment for that, some of the health economists have looked like like a 1-to-4 ratio. So for every dollar we put into suicide prevention, we're going to get a $4 return. That there's a lot more research that needs to be done in that space, but that's just one way to look at it. There are many other ways to look at it. And again, cost savings is a fairly cold way to approach this, but when it comes to it, business leaders are often forced with making difficult decisions on which initiative to prioritize and why. And sometimes feel good types of initiatives don't rise to the same level as help us be a productive business. For better or for worse, that is just the reality. So we need to make the argument that when we are operating in a psychologically safe environment, and I use that term broadly to talk about not only it's safe to bring up mistakes, it's safe to be who I am, it's safe to acknowledge that I'm having a hard time. When we do that, we see workplaces having all kinds of benefits. We have employee engagement goes way up. And right now in healthcare, this is possibly the most major issue we have. Our physicians and other healthcare professionals are exhausted by the impact of COVID. And it's very hard to keep talent. So having the ability for people to proactively to say, I need help way before they're coming to the point of burnout, mental exhaustion, and cynicism and suicidal thoughts, that's where we need to go. And when we do that, we not only save the costs of churn with our employees, but all kinds of safety issues and errors and mistakes that happen when people are just at the end of their ability to cope. It's understandable when people aren't sleeping, when they're overwhelmed by their emotional state, when they have feelings of dread and hopelessness and helplessness, that they're very distracted and they are going to have increased errors. They are going to have high levels of distraction, difficulties, problem solving, all the things that we need people to be super sharp with when they are working in a healthcare system.
I really love your approach and how you look at this. And I echo that, we can't put a price on human life. Um, I focus on this because in the world of physicians, in burnout and wellness, uh, financial cost has been tied to it. And that's really caused the success of wellness curriculums and decreasing burnout among physicians and really helped it explode by showing that there's a value add to that. And I find that sometimes in suicide prevention, we are a little bit afraid to walk down that road because of that question of what is a human life worth? But I think there's a lot of other ways of looking at it.
Exactly.
Among physicians, stigma is a huge issue. And it's not just unique to physicians and any other field and just society in general. Saying that you're struggling with mental health or suicidal thoughts has a lot of stigma associated with it. What are things that individuals can go today to their workplace that can help address some of those stigma issues that exist?
Yeah, and I'll give a brief answer, and then I also want to give a chance for Lois to weigh in because she's experienced this directly. So my first response to that question is how organizations have typically approached stigma reduction is problematic. And by that, I mean, they just talk about it. They just talk about the stigma of mental health conditions, the stigma of suicide, stigma, 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 stigma. And what we know about the human brain is that we are wired to remember negative things. So if all we talk about is the stigma of mental health, guess what? We are just reinforcing that connection. I like to think of it more of what it really is, which is about bias and misinformation, preconceived ideas, discrimination, and so forth, and really putting the onus on each of us to acknowledge our own internal bias around these issues. If we look at Dr. Patrick Corrigan's research on how do we reverse this, it's not just raising awareness. That in its best, raising awareness around these issues has what we call a state trooper effect, which is we change our attitudes maybe slightly when everything's right in front of us, but in the long term, we tend to go back to whatever we were doing before. It's just not sticky. Another approach of shaming a bunch of people for holding, bad, stigmatized, or biased ideas actually has the reverse effect. People hunker down, they self-protect, and the situation gets worse. So really, the only way through is by people sharing their stories of going through difficult times, what they did to cope, how they reached out, how they've learned through this, the trials and tribulations, what was beneficial to them, and making this a human issue, person to person, rather than those people over there. It's all of us. All of us have to acknowledge this on some level. There's hardly anybody who's not been impacted by some kind of mental health crisis, either themselves personally or one degree of separation. When we don't talk about it, then in this way, by sharing stories, then we just assume everybody else is fine. One of the beautiful things that happened last night is we had a Twitter chat with a lot of members of Lois's committee, and a lot of them acknowledged their firsthand experience with these issues, how they had come through their own suicidal despair, how they had survived a suicide attempt in the medical community, and how that bias and discrimination against them impacted them so significantly, and what they have done to get back on their feet. So I'll just turn it over to Lois for a second to also address her experience with this as well.
Well, thank you, Sally. And I appreciate all that you have done in this space of workplace suicide prevention. And I am also one that believes in stories. I think that those stories of hope and recovery are the ones that do make a difference for other people. When you see somebody else who's had trials and tribulations and are able to recognize that there is another side and that you can get through whatever difficulties you're getting through in a positive way. So for me, when I had issues with suicidal ideation, creating a suicidal construct, I kept that to myself. And I kept that to myself for a very long time because I was afraid of what other people would think, that I'd be the weak link, how that would stick to me for the rest of my professional career. And what I found is in talking about those episodes, and it's easier in sort of hindsight to be brave once you've gotten to the other side, that I have found connection with other people. That connection, that human connection, that interaction, I think is really important. So I liked what you said about the healing coming from sharing the stories. I did want to ask you about how you've almost operationalized workplace suicide prevention so that maybe those in the medical community that are trying to think about how to build a program, do you have suggestions?
Yeah. So I just want to respond to both a question I didn't fully answer for Perry, and something you also broke
Oh,
up was, which is, what does a perfect intervention look like? And for me, the intervention, at least in part, needs to be about peer support. And I know there are physician, assistance programs and so forth, and it just needs to have an informal quality as well as a formal quality, so that people like and others can find their peers quickly and easily, with not a whole lot of bureaucracy or fear of punishment for doing so. Like any health issue, and physicians know this so well, right? With any health issue, the earlier we can start to address it, the better it's going to be. And so by making it very easy and matter of fact, and this is just what we do around here, starting with some kind of peer support conversations with peers who've walked the path, that's going to make a huge difference. And so I do see this as the future of suicide prevention. When we went to operationalize the national guidelines for workplace suicide prevention, which can be found at workplacesuicideprevention.com, first we started with listening. We listened to all kinds of industries. We listened to all kinds of roles: HR, employee assistance programs, peer supporters, health and safety people, executives, even financial people, wellness people, all kinds of people weighed in as well, in equal measure, people with lived experience. We wanted to make sure that workers who had lived through their own suicide crisis, thoughts, attempts, or a suicide death, or caregiving role, had equal say, equal footing at the table as all of those other roles. And a lot of times people had multiple hats on, for sure. So we did focus groups, in-depth interviews, a national survey. We looked at what other countries were doing: Australia, the UK, Canada, We looked at other best practices and so forth, and we pulled together 8 guiding principles and 9 practices that help organizations of all sizes. We've now just done our second year evaluation of these guidelines, and I can tell you it's really, really exciting to me to see small companies, large companies, all different sectors, government, nonprofit, business, all different industries and so forth, leaning into these. We have about 750 plus what we call pledge partners, organizations that are implementing the guidelines, and they cut across all of these issues saying that they're relevant. So just briefly to kind of share with you what this looks like, we have divided the 9 practices into what we call upstream, midstream, and downstream approaches. On the upstream level, we're doing what I alluded to earlier, which is really working in a very intentional way to shift culture. That is the biggest part of the iceberg. If we don't get that right, doesn't matter what the heck we do in all the other tactics. It just doesn't matter. And so how do we shift culture? We look at top-down communication from the leadership. We need a very passionate advocate up there at the top level saying, I get this, and I get this on a very deep level. We need to look at job strain. So one of the things that was very clear from the Twitter chat last night is it's not good enough to get a whole bunch of troubled physicians to counselors. It's just not going to be good enough. We also need to look at what the industry, what the environment is doing to our physicians, to our healthcare professionals, that is just driving hopelessness and driving despair and driving exhaustion. And I get it. It is a very difficult conversation in the era of COVID to figure that out. But we have got to address the environmental issues and mitigate them as best we can, or we're just going to keep losing our healthcare professionals. So driving the culture from leadership, driving the culture from looking at job strain, psychosocial hazards, and then also having kind of a bottom-up communication strategy where we are talking truths, where people are sharing their stories. And then in the middle, the midstream efforts, this is really about catching problems as they're emerging and not waiting until, as we say, they're stage 4 or where they're catastrophic or where, the plan has already been set and the person is moving towards that action. We want to catch this at first thought. The first time the thought comes into the mind, I just can't do this anymore. And again, having an easy way for people to disclose that in a safe space, usually to peers. So how do we get there? So we do that through, we have various forms of suicide prevention gatekeeper training now, especially ones that are focused on physicians and healthcare industry. The Question Persuade Response Institute has one that's focused on medical professionals. We are working in partnership with the Colorado Depression Center. We've got one that's specifically organized for workplaces. There are resources there. They are cheap. They are short-term. There's no excuse, just like CPR. There's no excuse not to implement them. So how do we empower our peers to come at this compassionately, come alongside people, walk with them, and help being a very helpful bridge to known and effective resources? We also need to self-empower people through screening and other tools to say this part of my wellness, this part of my well-being matters just as much as if I do exercise and take my vitamins and eat my fruits and vegetables. I've got to put in practices every day that give me a fighting chance to have my mental health be as best as it can be. So having that self-empowerment piece. And then on the downstream part, here we're really talking about being prepared for crisis. When people are in the throes of crisis, again, whether it's a post-attempt, a near miss, a death, our workplaces need to be prepared with a response, not reeling to figure out how to sweep it under the rug or cover our butts from litigation or that kind of thing, because our post-vention practices matter greatly for all the people left behind. So do we know? Do we have a plan for how we're going to respond when people are disclosing intense suicidal thoughts? How do we come alongside them in their moment of deep, dark pain and approach them with dignity, respect, and collaboration? Do we know where the best physician-related crisis resources are that are trustworthy? If there has been a death, how are we going to respond to all the grieving coworkers left behind in a way that acknowledges their grief and their trauma and then transition that pain into the next stages of prevention? I could talk about this all day, but I think I hit some of the highlights on some of the practices and happy to answer any additional questions.
I absolutely love that answer. Just to summarize, I love the, global upstream effects, changing the culture, because that's so important. When we talk about suicide, we're talking about cultural change. We're talking about top-down changes and on-the-ground changes. Your answer about this is like CPR spoke with me so much. It's something I talk about when we do gatekeeper training in-house, right? Our physicians know what to do when a code is called and you have to perform ACLS. They know what to do when a patient has a stroke, when a rapid response is called. But why don't we do standardized training regularly and update it so people remember on what to do when you have a coworker, a friend, a family member in crisis? And that downstream effect. It's not a matter of when, it's a matter, or it's not a matter if, it's a matter of when that suicide is going to occur and how you as an organization and individual are going to respond. Those are such great answers. There was so many great things in there. If you have any more questions, I very strongly urge you to go to our website and read more about it, reach out. There are amazing resources out there. Both Dr. Swisher and myself very, very much highly recommend it. And I hope every hospital system across the United States plays a large role in it. Before we finish up, do you mind sharing that website one more time for everybody? So if they didn't have a chance to hear it, they can write it down really quickly right now.
Sure, absolutely. And I just also want to say I'm very encouraged. Again, we just did our 2-year evaluation. Healthcare was the #1 industry that has made a commitment to make workplace suicide prevention a health and safety priority. So way to go. Apparently it's been very needed over the last, 18 months or so. So yeah, the website is workplacesuicideprevention.com, workplacesuicideprevention.com. And I guess my final words to all of you are: be vocal, be visible, be visionary. There is no shame in stepping forward here, but there is great risk in holding back and just hoping for the best. Join us.
Thank you so much again for what you do and all the changes that you made so much. It's absolutely incredible. I feel so lucky to get the opportunity to talk to you today. Thank you for taking the
Likewise,
time.
and congratulations on having this day be so successful.
Thank
Before
you.
we sign off, I want to say one thing about the website. If you go to the website, there are multiple steps, but something today that every institution and every organization can do is that they can take the pledge that they're going to work on this.
That's
It
just the
is
first
a
step, the willingness. Yeah.
Yes, but it is that visible sign that you are going to want to be vocal and you are going to be that visionary, that you're taking the pledge and you can show other people your start to commitment. And I think that that is just such an important place in moving from this being an individual's problem to something that all of us can work on and making better health for our healthcare workers. Thank you for what you do, Sally.
Oh, absolutely. So somebody's asking for the website in the chat, and
We will make sure to add it into the chat. It'll probably happen after this interview is over, but it will be in there soon.
okay, I'm trying to do it quickly, but not quickly enough.
Someone
Pressure.
else did it. Thank you very much.
Thank you.